Okay, now it looks like I'm live. This is now something different from what I typically do. So I figured why not trying out a live stream, which is really something I have never done before. And basically live streaming is nothing else than a webinar, I guess. You can chat with the YouTube chat, you can ask questions, you can comment on anything. I'm not even sure if anybody wants to watch this. So I asked my patrons a few days ago and they were quite in favor of having a live stream, and you can also watch this as a replay, of course. But yeah, now let's start with the case. So basically this is a case that I saw a few days ago, and it's about ankle MRI, and it was an injury 2 days prior to the scan, as you can see with all this edema. And what I'm going to do now with this live stream, or during this live stream, is go systematically through the case, pointing out a few findings, just giving some thoughts about how I approach cases like this. So we can go here to the overview. As you can see, it's quite an extensive protocol here from that institution, and I have all the labels off, so not to fall into some kind of issue with patient data, although it's all anonymized, etc. Anyways, but I think the year of birth is given on this program even after anonymization, so I just gonna prevent this. Yeah, so basically let's start with the STIR, or with this PD fat set sequence. It's always a good way to start this kind of analysis. Yeah, and I have 2 viewers now, that's crazy. Okay, so anyways, so when you scroll through the sagittal PD, you immediately see bone marrow edema lesions, you see all this soft tissue edema, and this already gives you some kind of indication how acute the trauma is or how severe the injuries are going to be. Just scrolling through here, having an overview here, and if you have read my book, you know that I typically work with templates with these different subheadings, and the first one is joints. So I'm now going to focus on joints and injuries of the joints, and what I always look at immediately is there joint effusion in the ankle joint, basically. And you can see here we have quite a large effusion in the ankle joint here. Normally it's not that much fluid here. This is already something that I would mention. Then we can switch over to some coronal sequences to see whether we have any kind of cartilage damage. So basically just running through the cartilage sections here, and they are most often in these locations on these shoulders here of the talus, right? So any small cartilage defects would be worth mentioning. So you will sometimes see such strange signal changes in the cartilage, which we don't really care about at this point. So I think the ankle joint itself looks rather unremarkable. There are some 3D sequences, but you can see the resolution is so low, it doesn't really make sense to really go through them. So anyways, now switching over to the subtalar joint, just do the same thing, basically look for any kind of joint effusion. There is a little bit of effusion here, as you can see here outlined with this recess. Cartilage in this posterior facet looks fine, and then we can see this pretty bright bone marrow edema here on the medial aspect of the talus, right? Then there is some flattening of the talar head on the plantar aspect, which is quite a frequent finding. However, you can see it's still flattened a little bit here, but the bone marrow edema is more located here, so this is probably a condition after an older injury already. So might not necessarily be an acute. Well, this one is certainly acute, but I mean just the flattening itself is probably not from the trauma 2 days ago, because I would expect way more edema here if that would be an acute injury. So, but this is certainly like a acute trauma. Well, you can say it's bone bruise, but if we go through the other sequences here, you can see it's this area here. I think there is a T1 somewhere. So this is a T1 weighted sequence. Talar head, go backwards. So this is where we have, I'm not sure if that's really well seen on the stream, but it's a little bit irregular. We don't always see cortical bone nicely, so it might actually be also a fracture. And if in doubt, so you can either say it's just bone bruise, which will be correct anyways. I mean, it's not like a real relevant fracture with destabilizing any kind of joint or so. Or you can say, at least in Germany, something like a subcortical infraction, which then indicates there is actually damage to the, to the trabecular structure, and but not really seeing a fracture line. So these are kind of the two dictations that I would use here. So going back to my first sequence here, so subtalar joint, then we can already see there is a little bit of edema here at the level of the, oh, that's not good, at the level of the anterior process of the calcaneus here, very subtle, and this is frequently very subtle, and you can scroll over here, and what we can see here now is a avulsion fracture of the anterior process of the calcaneus, and this is where the bifurcate ligament has its origin. So this is something that frequently happens in this kind of distortions of the ankle joint, especially if it's not the normal ankle joint but more the shopper line that's affected. And you always have to be very careful on MR not to miss this, basically, because they can be very subtle, and because it's an avulsion fracture, we typically do not see a lot of bone marrow edema. Bone marrow edema is more a result of compression forces rather than distraction, and this is, let me just pull up my pen here. So this is a tiny fragment here, okay? So this is already a finding we have to keep in mind, because we now have to focus really on the chopard joint line to see whether there is any other injury. Okay, cartilage here is good, cuboid, maybe a little bit bone marrow edema here, but this might also be a partial volume. We can check on our other sequences here. And something you should realize now on this image is, so we can see the calcaneocuboidal ligament joint here, and what we have is a large effusion here already. That's not normal. So this should raise suspicion of a injury also in this joint line. And you can see the joint capsule here. It's very irregular. We don't really see it attaching here onto the lateral aspect of the cuboid. So we are suspecting a rupture of this joint capsule here. We can see this probably better here on this T2 transverse section. So going up here, so it's the ankle joint. We scroll down, talar head, navicular bone, calcaneus, cuboid, and you can then nicely see the joint capsule here. Probably part of it still here, and then it's somewhere disrupted at this level here. And all in between here, this is joint effusion, as we can see nicely here. Sometimes you see cortical flakes or avulsions here, which is hard to say on MRI. We don't see bone marrow edema again. The cortical bone is not well demarcated here, but it might as well be a tiny cortical fragment somewhere here. That would be a question for a radiograph, but I don't have one, unfortunately. I don't know, can you even hear me? I hope so. Otherwise, please let me know in the chat. Still see 17 people watching this at least. All right, so going back to this one here, we now have like this avulsion here, bifurcate ligament avulsion from the anterior process of the calcaneus. We have the lateral joint capsule rupture here, also one of these ligaments that are enforcing this joint capsule will be torn. I'm not sure if I can do this now. Can you see this? So in case you can see this, I think it should be shown. These are the two ligaments, so the calcaneo-navicular ligament and the calcaneo-cuboid ligament, which together basically are the bifurcate ligament, so just this V-shaped ligament here, and this is the avulsion of this ligament. And the one on the lateral aspect, it might be just a joint capsule or this dorsolateral calcaneo-cuboid ligament, but it's not really separable anyway, so it's just the joint capsule. I think it makes it much easier. So hiding this. All right. So moving on here. So we have injury to this joint. Now we really have to check the talo-navicular joint, and what you can see here is this kind of elevated cortical bone here. So this one here and some high signal below it. The joint capsule itself is this one here, attaching to this kind of cortical bone here, And again, we don't see like bone marrow edema in the talus itself. So this one is an avulsed cortical fragment. So this one should basically sit down here. And again, because it's an avulsion, we don't see a lot of bone marrow edema, because this is something we frequently see, avulsion fractures without bone marrow edema. You can see the joint capsule itself is thickened. It's also like really abnormal. So a little bit of a fusion, but not too much. And on the navicular side, everything looks kind of okay. So now we have all the joints back here. You can quickly go through the Lisfranc joints here too, checking for osteoarthritis or any kind of bone marrow edema, fractures of the metatarsal bones, which here is not the case. It's also always recommended also checking this on this kind of coronal views here of the foot, because you can really nicely see the alignment. You can see these different ligaments, Lisfranc ligaments here. But that's all good. Especially there is nothing going on at the base of the fifth metatarsal, right? Okay, now that's it for the joints. Now the next thing on my list will always be the syndesmosis. So T2, any transverse section basically will do. You just scroll to the top, scroll down, and you can see it's starting on the tibial side, running down here to the fibula. And it has these different like bundles, if you will, and this most inferior one can be a little bit more prominent, and it has been termed the Bassett ligament. However, it's just the normal part of the anterior syndesmosis, and it's not like a separate ligament in this regard. And I think it's just one of many misnomers that are going on. Oh yeah, you can hear me. Oh, that's nice. Thanks for the feedback. Yeah, well, basically the syndesmosis looks normal, normal black signal, like hypointense, nothing going on there. And here again, you can see these different bundles, and then here this Bassett ligament, if you will. Posterior syndesmosis looks rather okay too here. We can also check on a T2 sequence, nothing going on. And one good way also to look at the syndesmosis is on these coronals, because you can see this kind of interosseous components that are running like down in this direction, right? You can see it here, here. So if you have a lot of edema in this region, you should be a little bit more suspicious of any kind of injury to the syndesmosis itself, but it's actually pretty normal here, so no injury. And if you see something like this and the fibula is okay, make sure you don't miss any kind of mesonerve fracture. So syndesmosis is fine. Then moving on to the lateral ligaments. So we can maybe start with any kind of transverse section is basically fine, and always start off with the LFTA. And you can see here there are at least some fibers going through, right? Then here it's a little bit less clear. We have this kind of ligament here, which is I would say and freely, maybe a little bit better appreciated here. And in all, it's too thick, right? So it's not like a normal ligament. We have a little bit high signal here. This one seems to be disrupted. This one is thickened and too bright. And then we have one portion down here which looks still okay. So this is consistent with a partial tear of the LFTA. Maybe it was even a pre-existing injury that was now a little bit like re-traumatized. You can also see there is edema around it. It's not just the ligament itself which is abnormal, also the surrounding soft tissue. So it's not just everything like old, so it was certainly also a acute component here. The next ligament is the LFC, the ligamentum fibulocalcaneare, and this one here is a very good case why you should always look also on non-fat saturated images. You can see there are some ligament-like structures here. You see something here, but it's quite the same signal intensity as the fatty tissue here. You could easily mistake this for a tear because it's not well visualized. So if you go back to maybe a non-fat saturated image here, PD non-fat sat, you can see it starting here at the tip of the fibula. It's running just, so here are the perennial tendons, here and there. It's going always like in this direction, the LFC. So it's still visible here, then it takes this curve and then it's running down here and inserting onto the lateral aspect here of the calcaneus. Here and here. So it's still in continuation. This the most distal part here is maybe a little bit too bright for my liking. We can go and verify this on this one here, on the fat saturated image. So here it's rather okay, maybe not like in a very young normal person, but also not like acutely injured. But this one here it gets a little bit too bright, so it's probably, you can either say it's a very mild partial tear or just like a strain basically. Also a lot of edema here. I think this was like also again a mix of a acute injury and with a pre-existing old little bit scarred LFC. The ligamentum fibrotalare posterius, here you can see this kind of wavy appearance that it has, and this is normal, doesn't mean that there is something going on. We can also see it nicely here, so you can also see these fibers going through, especially here. And this one looks like a cat, right, or a mouse, and it's kind of the mustache of this ankle joint. Now you can hear the baby in the background. It's not that I don't care, but my wife is taking care of it, so don't worry. Someone once was suspicious that I would have some cats or something. I don't. Okay. So this one is also normal, right? Nothing special going on there. So we have now covered the lateral ligaments. Now moving on to the medial ligaments, and here you can start with the coronal view, which is also perfectly fine, and you can see here we don't have any like bone marrow edema. We don't have a stripping of the deltoid ligament here, like sometimes you have this sleeve avulsion or this fascial sleeve when you have a stripping of the deltoid ligament from the malleolus. Here I have a separate video about this actually. Then we always make the distinction between the deep and the superficial fibers basically, and you can see here the deep portion of the deltoid ligament. It's not really nice, we can not really see the striation very well, so this is either probably a old, a little bit scarred ligament. It's probably not acutely injured because it's more on the lateral side and the chopper joint line. And then we have the superficial portions here, tibial spring. So this is the tibial spring ligament here, running into the suprametal portion of the spring ligament complex. So there is like no tear going on there either. And then we can scroll quickly through, and on the maybe even on the non-fat saturated it might be even more obvious. So this is the portion here going to the calcaneus, then tibial spring, and the most anterior one, tibio-navicular portion, is sometimes just not visible. I wouldn't really care about it. Don't spend too much time trying to find it basically. So nothing acute going on here. Whilst at the medial ligament, always give a look at the spring ligament, and you can just scroll down to the calcaneus where you have this 90-degree notch here. This is where you have the origin of the medioplantar oblique and the infraplantar longitudinal portion, which don't matter, so I just give them a look, but they are basically not important anyway. So the important one is the suprametal portion, and it's the one that's connecting the calcaneus with the navicular bone here, more or less in that direction. And you can see it here, so it's beneath the posterior tibial tendon, this one here. And then it has this kind of thickened appearance, and then it gets a little bit brighter in signal intensity. Sometimes it also thins out a bit, but this one here looks now perfectly normal, so nothing going on, no tear there. And you can also see it here, that this kind of hammock where the talar head lies in. There might be some edema down here, but the suprametal portion itself here looks fine. So also, this kind of gap here is not indicating a tear, but it's sometimes just a spring ligament recess, which is normal because we are kind of having this ligament that is running obliquely, and therefore we are cutting it out here, when on the next slide it's coming back here and inserting nicely there. Obviously we have the joint capsule that is injured too, because we know that we have this shop bar injury with this avulsion here. So we expect some edema around this ligament, but it's not actually a spring ligament injury. So that's that. Then we can switch over to the tendons. Now we can go a bit faster. We can see a nice Achilles tendon. Plantar fascia is perfectly fine here, right? Nothing going on here. At this level, Achilles tendon fine. Then don't forget the extensor tendons. We can see, especially sometimes, irritations at this level at the insertion of the anterior tibial tendon, but this one is normal. Then the other extensors here are fine. One thing you frequently see on most acute ankle injuries is a little bit of edema at the origin of the extensor digitorum brevis. It's not so easy to see here in this case, maybe on a different sequence. The best one is probably this one here. So this is this muscle belly here on the dorsum of the foot, and it has a similar origin. Its origin is at the lateral aspect of the calcaneus, and you can see how we have edema there in the muscle, and even this tendon slip, this central tendon slip here, looks a little bit wavy when it shouldn't be. It should be like pretty straight actually. So there might be actually an injury here of the origin of this extensor brevis muscle, and this is something you frequently see, but I'm not really sure about how important it is. It's probably just painful and will resolve by itself eventually. There it is. Then that's all for the extensor tendons. Moving on to the flexor tendons, best seen on this kind of axial here, and you can see posterior tibial tendon sits in the groove, so it's not like dislocated or anything. There is a little bit of elevation here of this kind of fascia or the retinaculum that is inserting here, but it doesn't look like an acute injury or anything, because then we would have more fluid down here. But always make sure you don't have a stripping here of the periosteum and its flexor retinaculum insertion. The other two here are fine, Tom, Dick and Harry. Nothing special going on. You can follow them all through the plantar side of the foot, doesn't matter. And then, very important, the perennial tendons, obviously. Just because, let me just try where I can chat too, so you can actually see it's live. Okay, so we have a normal variant here. This is a peroneus quartus here, this very black tendon that's inserting onto the lateral aspect here. Very common and frequently not described. I'm not sure whether people just don't like to describe it because they think it's just normal, doesn't really matter, or whether they don't see it. But with all these anatomic variants you can see down here, they are most commonly missed on reports, like even peroneal calcaneus internus or flexor digitorum accessorius longus, etc., which might actually be clinically relevant. They are frequently not reported. Even a soleus accessorius, which is a very large muscle bulk here. And the reason is because it just doesn't look abnormal if it's not injured. So, but always give this musculature a good look. Now, peroneal tendons here, the retinaculum, this kind of like tiny triangle here. The insertion here looks rather good. Then tendon, the longus one and the brevis one. There is a little bit fluid in the tendon sheath that you can appreciate here and maybe here, surrounding the tendon here. And the other tendon is there. And there is some fluid in the tendon sheath. We can also quickly see this maybe here. So, right, this is the lateral side tendon. So there is some fluid along the tendons. And if this is just, so the injury was 2 days ago, then I wouldn't talk about a tenosynovitis. I think it's just bleeding inside the tendon sheath. So it's probably just blood there and not really inflammation in the sense of a tenosynovitis, which if it's a few weeks after trauma and you still have fluid, then I would probably just say this is tenosynovitis of the tendon sheath, which can also happen of the perennial tendons after a injury, and is quite frequent, associated with tendinopathy, etc. Now they did a, as you can see here, some kind of a oblique transverse. So basically these are, you can see it here, it's an oblique transverse, and if you have the foot in neutral position, it's kind of good, because you, especially if you do it in T1, but it's also okay in T2, because you can a little bit alleviate this kind of cursed or course, this like bended course that the tendons take around the ankle joint. So sometimes it's a bit easier to see split tears, etc. And scrolling through here, everything looks quite nice and smoothly. We can also see the LFC here, how it looks quite okay, and then slightly brighter here at the insertion. We mentioned this already. And yeah, what else do we see here? Not much. So deep portion looks rather okay, so that's why I was thinking maybe this is an older injury that the patient had. Alright, that's it for the tendons. Then moving on to what's left, soft tissue. Just delete this. So soft tissue always assess the musculature here, down here. Sometimes you can see fatty atrophy of any kind of this kind of muscles, which might indicate a nerve entrapment, which is not the case here. In diabetic patients, you will see a severe fatty atrophy of all of the intrinsic fat musculature. But here we are just checking for hematoma, something like this, because it's I think it's a young patient. Yep, nothing special going on. And then lastly, you can describe any kind of soft tissue edemas you can see here. And just one thing I'd like to mention. So there's not a lot of swelling going on here on the lateral side especially, but if you look how straight this kind of skin is lined up here, it's because they stuffed this coil pretty well with any kind of material basically. And yeah, so it's quite flat. Yeah, so probably a lot of the swelling is not visible now, and but it's also indicating, if the swelling is not so much pronounced here, that the injury might not primarily have been the lateral ankle ligaments, because in this specific patient the injury was in the Chopard line here, which is a little bit more anteriorly, right? So with that, basically the conclusion of this case is a Chopard injury. So we have this avulsion here of the joint capsule, which is also thickened and injured too. We have a avulsion fracture of the anterior process of the calcaneus with the bifurcate ligament that's avulsed. And also at this level we have a injury of the extensor digitorum brevis with this kind of not very smoothly running tendon slip here and some edema in the muscle origin itself. Then on the axials we can also see here this joint effusion and the disruption of the joint capsule here, together with the ligaments that are extending here. Yeah, the video will also be available, obviously, like any standard YouTube videos. So this is not like one of these webinars. If you miss it, you lose. So feel free to watch it tomorrow. It's just a test. I want to see how it works. It's the first time I do this. Yes, it's actually, I think it's a 3 Tesla scanner. So I actually wouldn't know the exact scanner, but I think it's a nice one. Maybe I'll see the DICOM data, but I'm a little bit afraid if I open now the DICOM header that I might reveal some patient-specific data, which I wouldn't want to risk, obviously, on a live stream. So, but I would think it's a 3D. Yeah, I think that's it for this case. I think that's all I got for you guys for today. I think for the first stream, I'm quite happy with that. And yeah, thanks for watching. It's now already quite late. I might be doing this maybe once a week, not sure, depending on the feedback I get. Oh, what's that? That's not that. And we'll see. Thanks for tuning in. It's 35 viewers, which is, I think it's better than expected. And yeah, see you next time. Bye bye. Oh,